welcome to The Print, a new working paper by the Economic Advisory Council to the Prime Minister that was published last week shows that there is an increasing use of tobacco in India. So the household consumption has significantly increased. Now, we have with us to discuss what it means for the public health and also what can India do to address this growing menace of growing use of tobacco in India. So we are joined by Professor Chintamani, who's a chairman of surgical oncology at Sir Ganga Hospital in Delhi. And we are joined by Dr. Rakesh Gupta, who is the president and director of public health at the Strategic Institute for Public Health Education and Research in Chandigarh. My first open question to both of you is that the paper points to a very worrying trend. So it shows that India's tobacco consumption between 2011 and 12 and 2023 and 24, both expenditure and incidence of tobacco consumption has significantly grown across rural and urban India. So how do you see this and isn't this situation alarming? We'll begin with Professor Chintamani and then we can go to Dr. Rakesh.
Well, thank you for having me. And it's true. Actually, I'm not surprised by what the paper is showing. And you can see in general an increase in the consumption of smokeless form of tobacco all around, mainly on account of the ease of availability, ease of utilization. The stress, if you say, has increased, but the stress was always there. It's just that what is handy is used and abused more often. I personally think it's just another thing, like whatever you eat or munch or chew in the day, they just pick up this gutka, especially as you mentioned, and in any form or shape, considering the kind of advertisements that come out, that this is tobacco-less, this is not harmful, they're all harmful, and each one of them has some element of a degree of addiction that happens. So initially it starts as a usual munching, which of late has increased because people are just trying to experiment on things which may not be really beneficial for their health. So I think this is one factor, availability. Two, ease of consumption. You can just take it and keep doing what you have to do. Places smoking may not be permitted. You may not have a place to sit down and chat with your friends and have any addictive product, but this is something that just goes into your mouth and you just carry on doing your routine work. And then, of course, every habit, good or bad, is infectious. So it goes from one to the other. And if in the family one person is chewing it, there's a very high probability that others would start it. So it's a very worrying trend in general, and specifically considering the kind of oral cancer patients that I happen to treat, because that's the majority of cancers that we treat, especially in men, lung besides, and of course breast in women. So everywhere this has contributed. You will be surprised to hear that even ladies are chewing it more often than they used to in the past. Smoking is an obvious bad habit, but chewing may not be visible. So I personally think the incidence is rising and people are taking it mainly on account of the ease of availability, to the ease of using it or abusing it, and thirdly, becoming a part of your usual habit by watching others.
Yeah, I think you made a couple of interesting remarks on how we'll come to the point on what kind of patients are you seeing but we'll hear from Dr. Rakesh on how this trends look. How the situation looks, isn't it alarming, and how do we really see the findings of the study?
So, Dr. Chintamani, I think you raised the very apt questions. And the smokeless tobacco use is more of a problem in India than maybe other European countries. And it is surely, the paper shows that there's massive rural surge and urban spike is there. And there's a considerable economic and health burden is also there because it is cheaply available. Another problem is that though the gutka is banned all over India by all the states, but still it is available as twin packs, right? The pan masala is separate and the chewing tobacco is separate, and when you mix it, it becomes gutka. So that is the main problem, and the enforcement is very, very weak. So that I'm sure about that. So there has been this is the case of the informal market growth. And this dramatic rise suggests that current control measures, they are being undermined by a thriving informal and increasing accessible market, as I told you about the twin packs. Yeah, thank you.
So I also want to bring attention to the program, the India's tobacco control program that came around 2007 and 8. So, Dr. Rakesh, I mean, what was that program about? If you could, emphasize a little bit on that, and because these growing numbers reflect clearly that somewhere down the line the national program did not really work. So, what do you think about that, and why did it not work?
The National Tobacco Control Program, it was launched in 2007, and it continues, and more and more districts are being covered. Initially there were very few districts, just 42 of the districts were covered. Now almost all the states and the districts are covered under National Tobacco Control Program. And the problem is, the intent was correct, and they even offer services. Offering cessation services is an important task under NTCP. And they also wanted to create awareness against the tobacco. So that also they are doing. So almost everybody now knows that tobacco is problem. What are the harms of tobacco? So I think the problem is of the enforcement of the law. So we have excellent laws under COTPA, under Food Safety Standard Act of India, against SLT, and against SLC, even COTPA, some of the sections of the COTPA can also be used. Then the Poison Act is also there, and then Juvenile Justice Act is there. So there are a lot of good laws, but the enforcement is poor. So I think the National Tobacco Control Program, as it was a good initiative by Government of India, and but the problem is that the enforcement is poor.
Because you spoke about enforcement, I think there was a huge campaign about tobacco consumption, and there's nobody in the country actually who doesn't know that tobacco causes cancer. And
Yeah.
it's a huge campaign that went over the years, and now everybody knows about it. So, Professor Chintamani, I want to come back to you and know from you, in your personal practice, are you seeing any such consequences of this rise in tobacco consumption in hospital, and also particularly cases of oral cancer, lung cancer, or any related cancers? Is India moving towards a large scale crisis related to this?
Thank you. Before I answer that, I must compliment Dr. Gupta for bringing out some very, very pertinent points. One is about the soul of the program, and importantly, the body of it. So the implementation is the body, which is where we fail. And it is, he's absolutely right. It is not just about cancer that you should be talking, and nicotine causes so many other problems, and there's nothing good that it does to body anyway. And as you rightly mentioned, everybody is aware of it, but it goes on. It's like, you believe you're never going to die, although you see people dying around you. So it's the same old Yaksh question, which was like, you're surprised by what is very obvious. So coming to the incidence of cancers, as I see, because that's my field of work, and for years I've been seeing the incidence rising. And what is especially bothering is the younger patients coming with oral cancers, and you can typically pick up an Indian oral cancer. Indian oral cancer is typical of a quid cancer. Quid is what we call as a kenny, or a gutka is put usually in a place. And for the benefit of everyone, it's not tobacco per se. The nicotine changes into nitrosamines, which are carcinogens, in the presence of bacteria, and that needs some contact and a bad oral hygiene. So many factors get together. And areca and pan, when they take it, in no time, the oral cavity gets involved. And the sad thing is, it involves almost the entire oral surface, the entire oral lining, if I may call it, what we call as field cancerization. So it's one problem, that is oral cancer. Lung cancer incidence is rising, and we all know that it is rising faster than we believed that it would. And we are close to making cancer an epidemic of this country. And this certainly is a dynamite you're sitting on, or a ticking time bomb. It's going to explode anytime if it is not already. I must confess that in the last 10 years, the incidence must have multiplied at least 7 to 8 times. It is multiplying in geometric progression. To answer your question, the first part of it. And the worst thing is, most of these are related to smokeless form, which is what is, something that probably we are highlighting. That you don't see as many smokers coming with it. It is the chewers that come with it. And it's not men alone, it's women too. And on top of it, it gets compounded by use of alcohol and other compounding agents which make the cancer happen more frequently than usual, because we call it potentiating the damaging impacts of tobacco or the nicotine. Coming to the last part, if you look at the advertisements that you observe, many celebrities, for whatever reason, I don't blame them, it's their way of looking at life, these advertisements should not be permitted. You are glorifying a killer. We have established this is one situation like oral cancer where it is established as an etiology. We know tobacco, nicotine causes cancer. It is not just one of the causes; it's the most important cause. So this should actually be very, very strongly implemented. Now, the paradox in this part of the world is you may have a tobacco company sponsoring a oral cancer conference. And a lot of aggression needed in this direction. You need to be very, very active, proactive, and you just programs don't really work out. It has been seen world over. You wanted to spread awareness, as you rightly said. Most are aware that it harms. It's such an addictive thing. If it starts in children, young children getting it, you can imagine they will get cancers much earlier. That's what I was referring to. So
Yeah.
it's no longer a 60-year-old gentleman coming with a cancer. It's a even a 35-year girl, a lady who has just been treated of cancer, tobacco related. And even while she's in post surgery recovering, she's asking for her dose of tobacco. So you can imagine the addiction levels of tobacco. It's a serious problem. We should look at it very, very seriously.
Yeah, because you spoke about non-smokers, so can we sort of understand what kind of cancers are most directly linked to smokeless tobacco products? Because the study also says that the tobacco gutka consumption especially has gone nearly sixfold, and now used by more than 30% of households. So, what are the cancers that are directly linked to smokeless tobacco products?
Almost all, but specifically subsites in the oral cavity where it happens is usually the lateral sulcus, which is where they stuff their garbage, right? Or in front under the lower lip. This is typically the oral cancer of India. It is named as Indian oral cancer, the most common site. Otherwise, you may have it in the, some people keep it under the tongue, depending upon where you keep it. Like I mentioned, it requires three things: one, nicotine; two, bacteria, which means bad hygiene; and three, the contact time. So if they keep it for a longer time and their oral cavity is bad, of course, hygiene wise, because they can't clean it adequately, and towards the second part of their problem, when they're addicted, mouth opening gets restricted due to submucous fibrosis, which means the mouth doesn't open up adequately. So they are not able to even find out if something is developing in the backside of their oral cavity. So the most common sites are, as I mentioned, lateral sulcus, floor of mouth, under the lip, buccal mucosa, and in addition, even the throat cancers, which are oropharynx area. Although oropharynx and the lower cancers are caused by the human papilloma virus more often, in India, even tobacco can cause those cancers too.
Also wanted to know from you what typically is the timeline between starting, let's say, because a lot of users start chewing these products very early on, like you also said. So, what is typically the timeline between starting gutka use and developing precancerous lesions or any sort of oral cancer?
Well, it's a very subjective question. So, and the answer would also be with a range, right? So, roughly, if you look at the oral cavity and if you're using tobacco or a nicotine regularly for whichever method, initially it is in the form of pre-cancers. Mind you, they're not called pre-malignant, predisposing condition. They're pre-cancers. They become cancers, right? So, the term is very important. Now, Then we move on to a stage of what is called dysplasia, where the change starts happening towards anomaly or abnormality, and then comes cancer. So roughly about 5 to 10 to 15 years for the the initial leukoplakia, submucous fibrosis, those initial precancers, and dysplasia takes about 15 to 30 years, and 25 to or 20 to 40 years is when the cancer can develop. Having said that, you may have a thought in your mind, why won't everybody who smokes gets a cancer? Why won't everybody who chews gets a cancer? So we have a protective mechanism of, now we know there are certain genes which are called tumor suppressor genes like P53, etc. So they don't let it happen because they have a protective role to play. And mind you, if you add alcohol to it, the duration shortens because
Yeah.
that protection is gone. So if you understand it stage wise, initially 5 to 10 years. So if you started at the age of 8 years, you're already looking at 20 years, you would be getting some white patches, white and black patches, mixed patches, which are the worst. Leukoplakia is white, leucosme is white. Melanoplakia is black patches in the in the mouth or the oral cavity. And if they're mixed, they're likely to be more dangerous. And they convert to dysplasia, which is a step before cancer. So there is adequate time for it to be caught also. And there are lots of oral self-examination screening programs that have been running where we try to look into see, and the patient can look into the mirror carefully. In fact, we did that program. But the tragedy is a lot of them have such a bad oral hygiene. If you imagine somebody who's chewing gutka all the time, the oral cavity is so dirty, and everything is camouflaged. So you may not be able to actually see those early lesions in those cases. So by the time they come, most of them, they are locally advanced cases. It's that small little ulcer. Any ulcer which is not healing in the oral cavity is a cancer unless proven otherwise. It is a cancer in a tobacco chewer all the time. So that's how you can look at it. So it is
Interesting.
important. It's important to understand that it won't come when it is already so awkward looking and so awful looking. It may be a small innocuous ulcer, wart, anything which is not healing in the oral cavity. Take it seriously. Oral self-examination is something very easy for any person to do. You open up your mouth in the lighted mirror or light behind you, look and examine all your oral cavity. The videos are available on YouTube. But the tragedy is, the good thing is, if they start looking inside their oral cavity, they won't like it themselves. So they'll start cleaning it up. So this added up to that awareness should be actually the awareness. No point telling them tobacco is harmful. Everybody knows it. And there's no point just before a film starts or a scene comes and when the hero and the villain are smoking is injurious to health. That is rubbish because that doesn't help. You need to have stricter laws. No smoking on the screen. If you're showing it, you are being a yeah, this is hypocrisy. Then you're leaving it to somebody to take a call. Then we shouldn't be discussing how to stop it.
I'll come back to you, Dr. Gupta, on because the report says that tobacco use is highest among poorer households. So,
Yeah, yeah.
do we know anything about why does tobacco consumption tend to concentrate only in lower income, not only but mostly in lower income groups?
Yeah, I think this is a very correct observation because this tobacco usage, especially the smokeless tobacco, since it is very cheap, and maybe indigenous forms are also available. Not only the packaged forms, but the indigenous forms are also available. So that is the reason that why poor households, they use smokeless tobacco more, even more than the smokeless tobacco, but the smoking tobacco. But the smoking tobacco, the BDs, they are being used by the poor people. But SLT, I think, is more being used by the poor people. So I think that is a correct observation. So yeah, and the thing is that the poor, the people, they don't know about the harms of the tobacco. Though I think the awareness campaign has been very successful, but still there are some people who may not be knowing about the harms of the tobacco. They think that smokeless tobacco, it is a harm reduction thing, and it is better than the smoking tobacco. But it is not better than smoking tobacco. In fact, even as Dr. Chintamani said, that even the areca nut is carcinogenic, so it can lead to some mucus, oral some mucus fibrosis that it leads to. But they can also give pharmacotherapy also. but brief advice surely can be given by the because they are very busy people. So at least brief advice can be given by the dental surgeons. And I may tell you that the oral cancers, they are attributed to smokeless tobacco, and maybe even Dr. Chintamani will also agree because it has been his observations also. So maybe 90% or even more than that, oral cancers they are because of the tobacco usage, and overall 30 to 40% of the cancers they are related to tobacco use. Well, that is including smoking tobacco.
Because you mentioned BD use in poorer households.
Yeah.
So the data also shows that there is some sort of shift away from BD towards packaged products, like more packaged products like cigarettes, gutka, and as there's a rise in income over the past decades. So does this tell us anything about evolving tobacco markets in India?
Yeah, surely. Actually, as the income grows, they may shift from BDs to cigarettes. But the poor people they definitely use BDs more than that. And you see the graphic, the pictorial health warnings, they are not very clear on the BDs because the packages as such, these are also packaged products mostly, the BDs also, but the pictorial health warning is not very clear on this, and even on the packs of the gutka or the pan masala, they are not very clear. So that may be the reason that they don't know about the harms of the tobacco. So the poor people they may be using uh, BDs and smokeless tobacco more.
Okay. Okay. And I also wanted to speak about control measures. So, like taxation, warnings, like we've been speaking about advertisement, there are restrictions and all sort of warnings that are put in place. So, they have clearly been there for a very long time. But as we see that, are they even effective in today's market? And if not, what more needs to be done? Because this seems like everything that is being done is to stop use, but the use continues to grow. So what needs to be done?
Actually, there's a WHO Empower package, MS for monitoring the tobacco epidemic, and we have been doing it very regularly through GYTS, then also through the GATS also. So GATS 2 that was I think undertaken in 2016-17, and now it is due. So as far as the monitoring is concerned, India is part of GATS 2, and then there's the prevention. So we have to have laws against prevention from the second-hand smoke. So that is also there, but though it may not be enforced properly. And then the empower. So W is warning us. The pictorial health warnings are also there. So it has been a very long, I mean, haul. The, the the tobacco control people they have been trying hard to get the 85% of the pictorial health warning on the principal surfaces of the tobacco products. Though it may not be very clear on the BDs, it may not be very clear on the smokeless tobacco, but it is very clearly visible. Unless it is the product is illicit, otherwise it is very visible. 85% of the health warning, which is, I mean, biggest in many out of many countries. So it is the biggest health warning, pictorial health warning. And then we need to enforce the taps, that is tobacco advertisement, promotion and sponsorship. So the law again is good. The section 5 says that it has to be there. The surrogate advertisements they have to be banned. But as Dr. Chintamani said, that many of the celebrities they are now advertising for the smokeless tobacco.
We got to be radical about it. When we want to be radical about it, it's on a war front that you do it. You can't be friendly with people who talk about tobacco, negotiating terms with them, raising taxes. Nothing has helped. We don't I don't think this is going to work in future as well. Awareness, that's number one. Two, making it loud and clear, tobacco kills everybody in small amount, large amount, smokeless, smoked form. Alcohol is harmful, we should be coming out with it. Small amount is also harmful. There's nothing good that alcohol does to anybody. We need to be loud about it. And when we really bring it out, the rules will be implemented only by people. If somebody who's himself smoking or chewing tobacco and he's asking people to stop doing it, I don't think it's going to work. So that's where I thought I could add to whatever was spoken, because so much of information was brought out.
There's an interesting insight that I would like to bring your attention, both of you, and throw that question out. So the report says that moral hazard. It mentions that it raises concerns that expanding publicly funded healthcare is sort of creating some sort of moral hazard. To explain to the view to the listeners, so the government is spending on healthcare, and it says that because of the schemes like Ayushman Bharat and different types of public healthcare schemes, the out of pocket expenditure has reduced, right?
Yeah.
And still tobacco consumption is rising. So this study says that it raises concern that expanding public funded healthcare through these schemes like Ayushman Bharat and all could create moral hazard, where people take more health risk because they have insurance, they have a cushion behind them. So, do you agree to that interpretation? I will start with Dr. Gupta, and then we'll go back to Professor Chintamani. Briefly, if you could answer that question.
Yes, I agree that because the out-of-pocket expenditure has decreased because of the Ayushman Bharat scheme and other schemes by Government of India. So I agree with that. And many of the cancers, they are being treated under the Ayushman Bharat scheme. So maybe they don't feel a pinch. The people who are suffering from cancer or the cardiovascular disease or other NCDs, they don't feel the pinch that it is because of the tobacco, and they should stop using tobacco. So I think you are right that the document that says that it's a moral hazard. I agree with that. Yeah.
Okay, Professor Chintamani.
Well, I mean, I would agree with Dr. Gupta and also disagree. Not from him. I'm from the study. Uh, I don't think we see lots of rich people getting treated, and I've worked in the poorer hospitals too before. So I don't think anybody wants cancer. Doesn't matter if he has money or he doesn't have money. So I personally don't think it has worked that way. It could be a statistical goof up, but I personally don't think you can just because the treatment is available, they would not bother if they get cancer out of a product. It doesn't work that way. They don't think that far. It's not because they have Ayushman, so now they can smoke away to glory. Just because they have Ayushman or any other, insurance, they will drink away to glory. No, that's not true. It doesn't work that way. Tobacco is also available, so it is cheaply available. So they're able to consume it. They couldn't care less it is going to cause cancer. And Ayushman Bharat is going to protect me because even if I get cancer, I think that's going too far. If you were to reward them for not smoking or not chewing, I can understand this, but this is hardly a reward. Like you, but these NGOs should not get sponsored by tobacco companies, and also anti-cancer programs, anti-addiction programs, not sponsored by people. You got to be very, very clear on it. Either you have a free will society where it couldn't care less who dies of what, like they talk about the total freedom in the West, or we control it in a subtle way. So I personally don't think the other way around. I think this way up. The Ayushman Bharat has really made it easier for the families of cancer patients in terms of financial toxicity that would happen to them. But damage done is damage done. Nobody wants to smoke just because Ayushman will provide a cover.
Yeah,
Uh,
I agree with you, Dr. Chintamani, that Ayushman Bharat definitely doesn't lead to, I mean, they may not lead to prevention of the usage. But you'll agree with me that nicotine addiction is as bad as with the heroin. And
I agree completely. I agree with
yeah,
you completely.
and
I
the
agree.
people even when they are very seriously ill, they continue to use tobacco,
Their
the
hand
chewing
goes like
tobacco,
this.
as
Yes, you're right. I agree.
well as the smokeless tobacco. So
Ab-
that was my case.
No, no,
And
you're right.
yeah, and Sneha, I think there should be a question about the new emerging nicotine tobacco products also. If you want, if you
Yeah,
have
yeah,
time,
please,
you can discuss.
please go on.
Yeah. So actually, new emerging nicotine and tobacco products. So that is another problem with the tobacco use. In fact, the new emerging nicotine and tobacco products like electronic cigarette, the oral, but the enforcement of law is definitely poor. Like we have act against the usage of the electronic cigarettes, like the PICA 2019 Act is always there, but it is because the policemen who have to impose this law or the enforce this law, they don't know themselves, they don't know about the act. So that is the main issue. So it's a very old act, but only those things which are approved under the Drug and Cosmetic Act, they are allowed. So we in Punjab, we stopped, we banned electronic cigarette way back in 2013. The government of India banned in 2019, but under Drug and Cosmetic Act, we banned under Drug and Cosmetic Act way back in 2013. So I think that should also be considered, the new emerging nicotine products. So that is my take on it. Yeah.
Because I think from what I have heard, these new products, they are also very easy to consume because they don't smell. Uh,
Yeah.
Maybe something like that. I don't know what's that thing called,
Mhm.
because I am a non-consumer. Anyway, we'll come to the end of this by getting quick comments on, is there, I know Dr. Chintamani has already said that an American solution cannot work for India or elsewhere, but is there any global example that's leading? Is there anything to look and refer to in fighting India's battle against tobacco use?
Small countries that have succeeded, especially in Europe, and Austria being one. And you see, actually, it also depends on what Dr. Gupta mentioned earlier. Your policeman has to be educated about it. Law enforcers have to be, and smoking, chewing, not permitted in these regions. Help available if you want to get de-addicted. I mean, they're very aggressive on it, although they have, because they literally were dying of it. They were choking away to the smoking and related issues because it's a rampant problem there. So they got over it by multiple encouraging schemes. I mean, in lieu of not smoking or not chewing, the rewards happen. But fortunately for them, it's more of smoking that they have it. And one thing about smoking, which I forgot to mention, I personally observed and seen, especially in South, the reverse smoking, which continues to be, the fire, Mark Twain said, for smokers, the fire at one end and the fool at the other. In this case, both are on the same side. So, so
Yeah.
they have a very high incidence of tongue cancer and oral cancer. So instead of smoking outwards where you don't see the smoke goes in. So these are all sorts of variations that, because they in that society the smoke was not permitted, so they started smoking reverse, and that they found was more addictive and they enjoyed it more. So well, that is one place, and the other country I heard of was Cuba, although I'm not aware of their program.
And as I told you about the PICA, actually 34 countries in all over the world, they have implemented PICA. There are laws banning electronic cigarettes.
Okay. All right. I think that's all the questions we had. Thank you so much for joining this discussion, participating in this discussion, Professor Chintamani and Dr. Gupta. It was pleasure talking to you. Thank you so much.
Pleasure.
Thank
Thank
you,
you.
Sneha, and thank you, Dr. Chintamani.
Thank you, Dr. Pleasure.